Welcome to the conference session titled Living with Low-Risk MDS. Thank you for joining us. My name is Alice Hauk, Senior Director of Patient and Professional Services at AAMDSIF, and I will be moderating the presentation today. As we get started, we recognize the generosity of the corporate sponsors and the generous support of patients, families, and caregivers for supporting the conference today. Immediately following the presentation, there will be a question and answer session. If you are participating online, please feel free to submit questions at any time during the presentation from the Q&A icon in the engagement panel on your right. To submit a question or comment, type your question in the Q&A text box window, and when you have finished typing your question, hit enter. We will do our best to get to all questions. When asking questions, I respectfully ask that you do two things to help me manage the incoming questions. First, submit your entire question all at the same time. And second, please do not share private health information in your question. Our speakers cannot answer specific questions related to your health care. Today's specialist is Dr. Mikkael Sekeres. Dr. Sekeres joined the University of Miami Health System and Sylvester Comprehensive Cancer Center as Chief of the Division of Hematology, and they are our host institution today. He earned his medical degree and a master's degree in clinical epidemiology from the University of Pennsylvania School of Medicine. And Dr. Sekeres completed his postgraduate training at Harvard University and his internal medicine residency at Massachusetts General Hospital and a fellowship in hematology oncology at the Dana-Farber Cancer Center Institute in Boston. He chaired the Oncology Drugs Advisory Committee of the FDA and has been on the editorial boards for several medical journals and chairs scientific advisory boards for patient advocacy groups and research funding agencies. And we are proud to say he is the chair of the AAMDSIF Medical Advisory Board. Dr. Sekeres has focused on myeloid malignancies and particularly myelodysplastic syndromes and acute myeloid leukemia in older adults for his entire career. He has developed innovative therapies for myeloid malignancies, helped define the molecular biology of myeloid neoplasms along with clinical correlates, helped redefine prognostication, including innovative methods using machine learning and artificial intelligence, and helped define the epidemiology and patient-reported outcomes in these conditions. With that introduction, welcome, Dr. Sekeres.
Thank you. Thank you so much, Alice. That was like way too generous, and at the same time you make it sound like I don't get out very often, which is actually unfortunately true. It's so nice to see all of you today. Thank you for coming, both in person and online. And I always worry that I throw the Aplastic Anemia and MDS Foundation for a loop when I give one of these talks because I don't have slides. So I'm going to do this as a whiteboard talk, and that is going to involve participation from all of you. So if you don't feel as if you want to participate, that's fine, but I am going to ask questions and ask folks to try to answer a little bit. And I hope that in doing this, it opens up conversation, and I welcome questions at any time. So as they're coming in online, Alice, as they're relevant to what we're doing, I'm happy to answer them in real time also, so folks don't have to wait an hour to get their question answered. Okay, so I'm going to start off really, really easy. What is myelodysplastic syndromes?
I have no clue.
That's good. You know what? I didn't have any clue for a long time either, and guess what? Either do a lot of doctors and nurses. They have no idea what this is. So what were you about to say? You were about to answer? Yes, sir.
We want to know, there is a MDS is a syndrome or is cancer?
Ooh, I like that question a lot. So is MDS a syndrome or is it a cancer? Yes. But I'll tell you why. Yes, sir.
Well, the biggest thing that they ever did to harm MDS patients was to call it pre-leukemia.
I like that a lot, right? Pre-leukemia. How many people have heard that term before?
Well, VA
Others?
certainly heard it.
Well, yeah, so the VA uses it. I still hear it from folks who are told they have a pre-leukemia. So myelodysplastic syndromes, I want to know who the heck ever came up with some convoluted term like that also, right? But let me try to define it a little bit. Sorry, I've got to be on camera also. I keep telling them I've got a great face for radio, so they don't need me on camera, but they keep insisting I be on camera. Okay, so let's break down the term a little bit. And I'm going to use my whiteboard, but I'm also going to take a little bit of a mulligan because I had shoulder surgery 4 weeks ago, so I can't lift my arm too high. Okay, so myelodysplastic syndromes. Don't make fun of my handwriting. Okay, so myelo, let's go from here. Myelo refers to myeloid. Myeloid cells are bone marrow cells. So it's cells in the bone marrow. Dysplastic means bad growing. Okay, so very simply, bad growing bone marrow cells. You look at them under a microscope and they look abnormal. Anyone remember the movie Young Frankenstein? Right, when he grabs Abby Normal's brain? So they're abnormal. They don't look right. They don't look like normal cells under a microscope. Syndromes refers to the fact, now notice here, a bunch of us started to do this probably about 15 years ago. We insisted that syndrome have a plural, syndromes over here, meaning it's a collection of diagnoses. So one person's MDS can look very, very different from another person's MDS. One person might have an MDS where she's going to live with this for over a decade. Another person might have an MDS where it's at risk of turning into leukemia in a couple of months. So it's such a wide spectrum of what people have. We kind of have insisted that this keep a plural. This drives medical journal editors nuts because we put MDS and we keep having to insist on a plural with the verb that follows it throughout these articles. Okay, so bad growing bone marrow cells, and it's a collection of disorders. So someone raised the word cancer. Everyone here heard MDS referred to as a cancer? Okay, so a couple of months ago, literally just a couple of months ago, there was a suggestion from an international classification group for bone marrow disorders that we change the name. And they want to change the name to myelodysplastic neoplasms. What's a neoplasm? It's cancer, right? Now they're still going to call it, they realize that's really going to screw everyone up, right? So they still say it should be myelodysplastic neoplasms, but we're still going to call it MDS. Can't quite get that, but okay. But they wanted to codify the fact that we do consider these a type of cancer. Now, there's a huge spectrum of cancer, and I'm sure that everyone in this audience, myself included, has either personally or has family members who've had cancer, and you realize there are some cancers where the doctors go bananas and say, we need to treat this immediately. Some people get you into the hospital and treat you immediately. And then there are other cancers where it seems like the doctors are taking the slow train to treat it and to develop a plan because it's not a medical emergency. And MDS, it's the same thing. It's the same spectrum of cancers. Some MDS where we're taking the slow train and we say, you know what, we don't need to treat this right now. We can take our time, we can watch your blood counts, we don't want to interfere with your quality of life, drag you to clinic a whole bunch of times when you don't need it. And then there's other flavors of MDS where we say, okay, we got to treat this now, let's get this under control, because if we don't, things are going to turn bad quickly. So let's take even a further step back, and then we're going to start to move forward. What's cancer? Well, I got to keep moving, Bob, either way. If I move here, they yell at me. If I move there. So what's cancer?
My problem is I always think of it as a lump.
Good for you. Yeah, I do too.
I don't have a lump.
I don't have a lump.
I don't have cancer. I got something
All right, so cancer, very simply, is the uncontrolled growth of cells. The cells in our body are programmed. They've got blueprints in them. Those blueprints are called genes or chromosomes. And they tell a cell what it's going to do for a living, how long it's going to live, when it's going to have kids, and obviously when it's going to die. Right? So cells are programmed, and they're programmed with genes or chromosomes. And part of their growing is they're limited, and there's signals in the body to get cells to stop growing also. You ever notice that there are some, this is actually something that's in all of biology. You ever notice that most trees don't overgrow each other? Right? They have kind of a canopy and it stops next to the next canopy. It's something called contact inhibition in biology. It's the same thing with cells. They contact each other, they know to stop growing. Cancer's rude. Cancer doesn't know to stop growing. Cancer ignores those signals and overgrows other things. So when that happens in the breast, a woman gets a lump, right? Cells are outgrowing other cells around them, creates a lump. When it happens in the lungs, you get a mass. And those cells are going to outgrow not only lung tissue, they're going to grow into blood vessels. That's why people cough up blood when they have lung cancer. They're going to grow into nerves. That's why people get pain sometimes when they have lung cancer. But you don't have a lump, right? This is what we call a liquid tumor. So if the basis for MDS is bad growing bone marrow cells, this cancer is growing quickly, outgrowing other cells in the bone marrow. Now, you all are from the Miami area. You'll know what I mean when I say that the bone marrow is a high rent district, right? It's a limited space. It's in a hard compartment that's not going to develop a lump. So if this were a soft compartment, you'd get a lump. It isn't though, it's a hard compartment, right? Bone marrow is not going to bulge, the bone's not going to bulge. So these cells are growing in this fixed space, growing, and the normal bone marrow cells, because they're getting squeezed out, start to die out. So it's a little bit of a paradox. You have too many cells, too many bone marrow cells that are abnormal, and as a result, you have too few cells in the bone marrow that are normal, that are left. So those normal cells are the ones that make the red blood cells that bring oxygen to our tissues, the white blood cells, that's our immune system, it fights infection, and the platelets that help stop bleeding. So there's an inherent paradox in MDS. You have too many cells in the bone marrow, but they're abnormal, and too few cells in the bloodstream because the remaining normal bone marrow cells are getting squeezed out. Pause for a second. Any questions about that?
So is it always the white cells that are growing?
So what a great question. Is it always the white cells that are growing? So if you look at the bone marrow, let me kind of show you. I think it's so important, I don't know, maybe it's because I'm a science geek, but I think it's so important to understand the biology of what's going on in MDS so that then we understand what's happening in the body and then we understand how we have to treat it, how we're gearing those therapies. So in the bone marrow, let's say this is the bone marrow. You're about to learn why I went to med school and not art school. Okay, so in the bone marrow, you have a very primitive cell that starts out here called a stem cell. You heard of stem cells before? It's always in the news, stem cells, right? It's kind of like the primitive cell, the Adam and Eve cell that gives rise to all the other cells. And a stem cell is completely undifferentiated. It can, if you place stem cells in different environments, they can become a lot of different types of cells. That's why stem cells are so cool. You place certain types of stem cells, you place it in the bone marrow, it's going to become a bone marrow cell. You place it in the heart, it's going to become a heart cell. Right? That's why they're really cool, because they respond to the environment and they change how they develop over time. This stem cell then has a couple of daughter cells. And they become a little bit more mature, a little bit more committed to what they're going to become eventually. Right? They're closer to being a bone marrow cell. Then these daughter cells have a couple of daughter cells. And they become a little more committed, a little more mature. And then these have daughter cells. And they become much more committed, much more mature in the bone marrow lineage, in becoming a dedicated bone marrow cell and blood cell. And eventually, they go out into the bloodstream, and that's where they become the white blood cells, the red blood cells, and the platelets. Okay? So your question about white blood cells, is it always white blood cells? The answer is no, it isn't. The abnormality that leads to MDS, though, starts maybe as high as here. Maybe it's in one of these cells. So you can see how it can go down one of these paths. If it goes down this path, you're going to have abnormal platelets. If it goes down this path, you're going to have abnormal red cells, you're going to be anemic. So it can go down any one of these paths, right? And that's why people can sometimes have, if it's up here, it could go down this path also. And then you have abnormal whites and reds and platelets because it brought it down both lines here. So to some extent, it depends on when does this error occur in a cell to determine whether it's going to affect the reds, the whites, the platelets, or all three. Now, we think that this error actually occurs at a very primitive place, but doesn't become manifest until it gets to this stage or this stage, and then becomes more committed. But sometimes it happens, it gets committed down different lines here. Yes, sir?
From what you said, it sounds like platelets are the least important. And they don't fight, they don't do this, they just sort of clean up.
Interesting interpretation. I hadn't thought about it. I mean, platelets are important if you're bleeding. They become the most important then. But you're right. In a way, you're right. I mean, if you're saying to me which are the most sophisticated of these and which is the least sophisticated, whites are most sophisticated, number 2 is reds, and number 3 is platelets. They are kind of fragments of cells. They're actually not technically a cell. But you're right about that. Anyway, so you understand, so this is kind of the basic concept of how the bone marrow works. If you get an error in it, remember what I said, that this is a type of cancer. So then this cell, guess what, goes bananas and makes a lot of cells with the same error in it. And then these guys make a lot of cells with the same error in it. And all of a sudden you have a bone marrow filled up with these dysplastic cells, right? Because it's outgrowing other cells around it. Okay. Yes, sir?
Is there any hope of immunotherapy for MDS?
Yeah, I will. That's a fabulous question. I will get to that. There are a lot of investigations trying to look at immunotherapy for MDS. I will tell you, so far, immunotherapy has been unfortunately disappointing in any cancer that starts off with myelo. So myelodysplastic, acute myeloid leukemia, myeloproliferative, hasn't worked yet. It's worked much better if something starts off with lympho, right? Lymphomas, acute lymphoblastic leukemia, those conditions, it's worked much better. Yes, sir?
I've heard people talk about blasts. Is this what you're referring to? I don't know what a series of blasts is.
Okay, thank you for bringing that up.
I don't know if it's something you're going to deal with later.
That was the perfect timing for that question. Thank you. So another way that I think about how the bone marrow cells work is imagine that these are kids in school. Okay? So let's imagine that this up here is preschool. And now we're talking about kindergarten. And now we're talking about elementary school. Now we're talking about high school. And then they've got to go out and make a living. Okay? Because these cells go through progressive maturation. They become progressively more functional as they go through every step of this. So blasts occur when your kindergartners start growing like crazy, right? So they're immature cells. Everyone in this room, myself included, has blasts in your bone marrow. We have to, because you can't get to a high schooler unless you start out with a kindergartner. So maybe I have 1% blasts in my marrow. Maybe Dr. Chandok has 1% blasts in her bone marrow. Somebody with myelodysplastic syndrome might have 1% blasts in her bone marrow. But if this happens, if this cell, this kindergartner, starts to grow too much, then that blast percentage is going to increase. And in general, we say that with blasts, once you get to greater than or equal to 5%, that's excess blasts. That's too many. Once you get to greater than or equal to 20%, that's where we make a diagnosis of leukemia. So this whole notion you brought up before, pre-leukemia, right? It used to be called pre-leukemia because some MDS went into leukemia. We don't like that term because most MDS doesn't go into leukemia. So it unnecessarily frightens people, and it's inaccurate. Once you start to get excess blasts, you can see why then we start to worry about it going into leukemia. So the difference between MDS and acute myeloid leukemia is completely arbitrary. It's not like something magical happens in the body where all of a sudden this is a completely different diagnosis. It's not. It's that we decided that we were going to draw a line in the sand that doctors would remember to distinguish less than 20% blasts or 20% or more. Right? It's an arbitrary number. What if we defined it as 19% blasts? Would it change anyone's life? No. What if we said 21? No big deal. Now, I will tell you, there is a bit of a movement to scroll that blast percentage back to 10%. And in fact, one of these international systems, the one that wants to rename this myelodysplastic neoplasms, it's actually the other system that wants to do it. There were two that were published within a week of each other, and they differ. So it gets a little bit confusing now about what we call MDS and how we're going to divide the definitions of it. But the basics are still the same. As you get excess blasts, this becomes a more aggressive disease. And you may hear that blast percentage is going to be scrolled back to 10%. So if right now you have 12% blasts and all of a sudden someone is calling this leukemia, realize it's nomenclature nonsense. Okay, it's just that we're changing the definitions. It's not that your diagnosis is any different from what it was.
So do the blasts always come from the kindergarten or preschool? They don't come from the adults?
Yeah, that's exactly right. So blasts are immature white blood cells. They're kindergartners. Okay, so you can imagine if you think of this as a factory where we've got to produce workers who have a high school degree, right, to go and make a product. The product is the whites, the reds, and the platelets. If you imagine a bone marrow filling up with blasts, it's like a factory filling up with kindergartners to work the factory. They're going to do a terrible job in that factory. Similarly, the blasts aren't making the normal cells to make the reds, the whites, and the platelets. So as people accumulate more blasts, for the most part, the blood counts drop. Not all the time. I certainly have had patients where they have excess blasts and their blood counts look better than mine. I don't know how the heck that happens. So rarely that can happen. For most people, as the blasts increase, the blood counts drop. Okay. Yes, sir.
Well, I guess in my mind it's, are you trying to reduce the blast? Medications, the various things, or research, is it trying to get rid of the blasts or get the blast down to is that the goal?
So if people, so it's another great question with what, so I'm so glad you're picking up on that, right? This is why I go through the biology of this. It seems like painful if you don't like science to go through biology of this, right? But if you don't understand the biology, you don't understand the treatment approaches either. So you're asking a question that's spot on for the biology. If somebody has excess blasts, absolutely. Our goal is to reduce those blasts back to a normal level. If somebody doesn't have excess blasts, guess what we're trying to do? Well, we're trying to promote the growth of the normal bone marrow cells that are left. Right? It's nice to try to kill off these bad guys. If we can't do that, we want to try to squeeze every last ounce of production out of these normal guys to produce good reds, whites, and platelets. So the philosophy of treatment with MDS can be at counterpoints to each other. If you have very low-risk MDS, right, what's one of the first drugs that we use for somebody who has anemia? Hormonal therapy. We're going to give something called either, people have a lot of different names for it, Retacrit, Procrit, Aranesp. These are shots that are given to try to boost the growth of the remaining normal cells. If somebody has 17% blasts, our focus isn't going to be to try to boost the growth of these cells. It's going to be to kill these cells. Because these cells, as they grow, this is where MDS is really not a nice diagnosis. They release chemicals to kill these cells. So the more blasts you have, not only are they squeezing these cells out of here, but they're ensuring their own survival by creating even more space by killing the good guys. So our focus when somebody has excess blasts is, in part, really to kill this out, get rid of all these, so that these guys can grow better. Does that make sense? Okay.
No, I've always told people that I use dark because of alpha.
Yep. That's Aranesp. That's one of those hormones.
To force my bone marrow to make more bad red blood cells.
Well, it's going to force your bone marrow to make good red blood cells from the remaining ones that are left.
Because I'm told that the red blood cells only last for a month.
That's so a typical. It's a good question, Bob. So a typical red blood cell lasts 120 days. That's 3 months. But when you get a blood transfusion, you're not getting all the 120 dayers, right? That would be awesome if we could. But what we're doing is we're getting an average of however old the red blood cells are in the person who donated the red blood cells. So if you're taking an average of it, you're probably getting about, if 120 days is the normal survival, you're probably getting about 60 days. Maybe.
Best you're ever going to.
Yeah. So do you know how those hormones, I'll get to that in a second. I'm going to get to treatment in a second. But I'm glad you brought that up because I want to show you how those hormones work. The body is an amazing thing sometimes. Let's just talk about some basic statistics about MDS also. Do you know how many people in the US are diagnosed with MDS each year? Let me try to put it in context. There are about 220,000 women diagnosed with breast cancer, about 220,000 men with prostate cancer, about 180,000 people in the US with lung cancer each year. How many people are diagnosed with MDS each year? 2. I wish, believe me. My dream is that I'm put out of a job. Okay, so about 20,000. So about 20,000 people diagnosed with MDS. I'm going to clear this up a little bit. I made a big fat mess here. Okay, about 20,000. There we go, got the right number of zeros. About 20,000 people diagnosed with MDS each year. And how many people are living with MDS? So this is an incidence rate, right? When we say how many people per year are diagnosed with these are incident diagnoses. The way the government tracks it is through something called the Surveillance, Epidemiology, and End Results Program, which is a collaboration between the CDC and the National Cancer Institute. We just started tracking MDS in 2001. So it's relatively new, how long we've been kind of officially calling this a cancer and have been tracking it. This translates to about 4.5 per 100,000 people in the US. Lung cancer is about 70 per 100,000. So it is relatively rare. The official definition from the National Institutes of Health for a rare disease is something that affects fewer than 200,000 people in the US each year. So it's rare, right? It is sometimes why it's so hard to find information about it. Who gets it more, men or women? Men always get the bad stuff more, right? So yeah, men get it slightly more than women. It's probably about a ratio of 60% to 40%. Who gets it more? Whites or people of color? Whites get it more. It's probably about a little bit more of a ratio there. I think it's more like a 65 to 35 ratio. Risk factors for getting it? Who's at risk of getting MDS? Who's at higher risk of getting MDS? Older. Thank you. Age. Age is the biggest. Why is increasing age a risk factor for MDS? Why is the average age of somebody in my clinic 71 years old? Have any idea?
Because our bodies are deteriorating.
60 years old, most guys get.
Yeah.
Unless you happen to have had your boots on the ground in Vietnam,
So there are
exposed to Agent Orange.
so there are risk factors, and I actually agree with you, Bob, that Agent Orange is a risk factor.
Marines at Camp Lejeune. It's endemic up there.
Yeah, well, Camp Lejeune, the water was contaminated with benzene, which is a risk factor, so I think that's true too. So why is age a risk factor? Our bodies deteriorate. The other thing our bodies do is they accumulate genetic errors as we age. So imagine you're a cell. Remember back in high school biology? This is going to get ugly for a second. High school biology. I don't know if you're the same era as me, but they always show this one film in high school biology to explain meiosis and mitosis. And the film always showed this cell that was quivering. I don't know why it was always quivering. It was always quivering like this, right? And then all of a sudden that one cell would kind of split and create the daughter cells, right? And right before it splits, you have all the genetic material, the chromosomes lining up in the center like they're doing line dancing. And then that cell pinches in the middle, and each of the daughter cells gets an equal amount of the genetic material in it. Okay? So imagine a cell is 99.9% accurate at making a perfect copy of that genetic material. That means that 1 out of 1,000 times it's going to screw up. And one of those daughter cells might get a little bit more, one might get a little bit less. Now, most of the time, that's just genetic garbage. And our immune system, so getting to immunotherapy and why it's so important, scoops it up and gets rid of it. It realizes it's a bad cell, I better get it out of the body. But maybe one time out of 1,000, the immune system misses it. And it leaves a cell that not only has extra genetic material, but that genetic material gives that cell an advantage over other cells to keep growing. That's why most people get cancers in their 60s and 70s and 80s. Because statistically, it takes that many cell divisions, that many years, before that one cell is left behind that's going to keep growing. Make sense? So as we age, we've actually found that people have these abnormalities that are called, again, it's this crazy long term, clonal hematopoiesis of indeterminate potential, CHIP. They accumulate genetic abnormalities in these cells, and then that's the first step, that first 1 in 1,000 times, right? Where a cell gets extra genetic material and the immune system hasn't swooped it up yet. Then, if that cell acquires another genetic abnormality, and then maybe another one, it then leads to myelodysplastic syndrome. So as we age, we accumulate these genetic errors, and it increases the likelihood eventually we're going to get MDS. So myelodysplastic syndrome is not what I call a one-hit wonder. It's not that a cell acquires one genetic abnormality and boom, you have MDS. It acquires one, and then another, and then another. And we found that people who have MDS have, on average, 3 or 4 of these driver mutations at their diagnosis. Now, epidemiologically, this is really cool, actually. How do we know this? There was a study, one of my favorite studies of all times, was conducted by the Atomic Bomb Research Institute in Japan. And there's actually a research body dedicated to survivors of the atomic bomb in Japan. And They did a study where they looked at, they have information on where thousands of people were standing relative to the epicenter where the bomb was dropped in Hiroshima or Nagasaki. And they tracked these folks over time for health consequences. And they found that when they looked at these folks in the 1980s and 1990s, they were 17 times more likely to develop MDS than folks who were unexposed in Japan to the bomb. But think about that for a second. The bomb was dropped in 1945, and these folks didn't develop MDS until the 1980s or 90s, 40 or 50 years later. Crazy, right? That tells you what the prodrome is, how long it takes from that first genetic insult, in this case the atomic bomb dropping, to accumulate that second and third and fourth error to eventually have MDS. And that's actually why I agree with you, Bob, about Agent Orange, because I think we just haven't waited long enough for it to become manifest. I think that some of our veterans who were exposed to Agent Orange, which of course was contaminated with benzene, it's a chemical that causes MDS, and we just haven't seen the second, third, and fourth errors in enough folks exposed to it to see the kind of glut of MDS that's probably going to result from it. Okay, so that's epidemiology. I bet a bunch of you are interested in treatment for this. So I'm going to talk about lower risk MDS, and then Dr. Chandok is going to talk about higher risk MDS. And I got to keep looking at the clock and make sure I'm kind of on time for everything. Okay, so for lower risk MDS in general, we will say somebody has lower risk. They kind of satisfy three lower risk. They generally, we're going to focus on three areas of their MDS. The first one, we've already brought up blasts, right? So folks with lower risk MDS tend to have fewer blasts. In general, this is not 100% of the time, but in general, these folks will have fewer than 5% blasts in the bone marrow. Sometimes you can sneak in and have a lower risk diagnosis with excess blasts, but it's relatively uncommon. Okay, number two, we talked about the cells in the bloodstream and how many of those cells are abnormal. So in general, folks who have lower risk MDS will have fewer abnormal blood counts. So maybe these are folks who just have an isolated anemia, or an isolated low platelet count, or an isolated low white blood cell count. Right? Or maybe they'll have one that's really low and one that's a little bit low. But you're in general, for folks who have lower risk MDS, you're not going to see all three cell lines low, low, low. The third criterion has to do with the genetics, or what we also call chromosomes. And folks who have lower risk MDS will tend to have better risk genetics, better risk chromosomes. Now, when I talk about genetics, am I talking about something that you pass down to your kids or grandkids? What do you think? When you have abnormal genetics with your MDS, is that something that you're going to pass down to kids and grandkids? For the most part, no. Right? Because remember how we talked about MDS arising. It's from abnormalities in genetics from your own cells over a lifetime of living, sometimes because of just a statistical fluke. They just screwed up that one time and that led them down this path. Or because of a previous exposure, right, to something that caused the genetic change. That could be the atomic bomb. Well, we don't have a lot of people exposed to that anymore, right? More commonly, it's because people got chemotherapy or radiation therapy for treatment of another cancer. Chemotherapy and radiation therapy work by damaging the DNA, the chromosomes of cancer cells, and causes them to die. That's how the drugs that we give actually work. Well, as they're damaging the genetics, the chromosomes of those normal cells, they're also damaging, of abnormal cells, they're also damaging normal cells. And that can be the first insult of the 3 or 4 it's going to take for somebody to develop MDS. Sometimes it's the second or third insult. And what we're learning more and more, this is a kind of a brand new avenue of investigation, is that some folks are going into that first cancer, let's say it's breast cancer, and it's a woman who's getting chemotherapy and radiation therapy. She may already have one of those CHIP mutations, those genetic abnormalities that arise just because. If she already has one of those going into it, then the chemotherapy and radiation therapy is going to add a second or third to it. And that's when we afterwards say, oh, this MDS arose because of the treatment for the other cancer. Probably not as a single event. Probably it was one of those 3 or 4 that it takes to develop MDS. Okay, so genetics and chromosomes, we've over years and years and years, we've been able to define these as good, intermediate, or poor risk. And it's not any kind of magic of how we've looked at the abnormality and said, haha, this is going to be a bad risk one. It's because we've studied information from people over decades and identified people who have this abnormality have good risk, those who have this one have intermediate, and those who have this one have poor risk. So for genetics and chromosomes, people with lower risk MDS tend to have good or intermediate. It's unusual to be classified as having a lower risk MDS and have poor risk genetics. Questions about how we think about this? We don't have a staging system for MDS. One of the most common questions I get from my patients, what stage am I? Because everyone knows someone with breast cancer or lung cancer and they're given a stage. What's our stage? Well, if we were to stage it, remember MDS is in the bone marrow and the blood throughout the body. It would be stage 4 for everyone. That would be ludicrous. And stage 4 wouldn't mean they have poor prognosis. It just means it's everywhere. Because that's what staging means. It's how far has the cancer spread. So for us, we use systems that use this basis of blasts, abnormal blood counts, and genetics that assign a score to people. And those systems are called the International Prognostic Scoring System, or IPSS. Okay? IPSS, and we use the most recent flavor of this is the revised version, or a new one that's called the molecular version of it. What it does is it looks at these 3 components, puts it into a formula, spits out a number, and that tells us whether you're lower or higher risk. But the basics for all that, I always tell this when I teach board review courses to hematologists, people who have to do this for a living. I teach board review courses, and I see their eyes start to do slot machines when I talk about the IPSS, right? Because it's a little complicated. So these are the basics that I tell them. Just remember this: low blasts, abnormal blood counts, genetics, and you'll be able to classify somebody as having lower or higher risk MDS. Okay, so let's talk about treatment. For lower risk MDS, we base treatment on the predominating low blood count, right? So if somebody has, I'm going to divide this into low red blood cells, low platelets, and low white cells. It's a terrible T. Okay. So for low red blood cells, we talked already, the first step, usually, this isn't true for everyone, but usually the most common drug we use to treat people who have anemia associated with lower risk MDS are hormones. And the hormones are the ones that I talked about before. It's going to be Retacrit, Procrit, Darbepoetin. Their generic names, which I always prefer, is erythropoietin or Darbepoetin. And we abbreviate that as a whole. We just call them kind of EPO, erythropoietin. Now, kind of cool how the body works. Anyone have any idea which organ is the one to detect the fact that we have anemia? You actually have an organ in the body that does this. Have any idea? Liver is always a good guess, right? It's kind of this mysterious thing. It's, it's always the one they pull out of a body in a TV show. But it isn't in this case, it isn't the liver. The liver does help with us to form blood clots. It's actually the kidneys. And one of the reasons it's the kidney is because the kidney is the one that sees a ton of our blood flow every minute, right? Because it's got to help clean it. So on the kidney, there's a sensor that determines if we're anemic. It's kind of like, imagine there's a river running past you and you're sticking a probe into the river to say, okay, is there anemia? Is there anemia? Whoops, there's anemia. And then the kidney secretes this hormone, erythropoietin, into the body. And EPO goes to the bone marrow and says, make more red blood cells. And if you have a normal bone marrow, the bone marrow increases the production of red blood cells and resolves the anemia. So you'll see this, for example, if somebody has surgery, loses a lot of blood, this is the process that happens. They're going to have high EPO levels, signaling the bone marrow to make more red blood cells. For somebody who has MDS, the bone marrow says, I can't make more, I'm kind of broken. So you continue to be anemic, and then the kidney continues to sense this and puts out even more EPO and says, make more red blood cells. And the bone marrow says, I can't, I'm broken. So then you become more anemic, and the kidney cranks out more EPO to make more of a signal. So a typical person who has MDS will have a sky-high EPO level in the body because the kidney's making so much of it, but the bone marrow can't make more red blood cells to resolve the anemia. Despite this, there are some people who have MDS, for whatever reason, their kidney isn't making as much EPO. And that can happen if you have kidney failure, right? So people on dialysis get EPO shots. Why? Because their kidney's broken. It can't make as much EPO as it should. Or sometimes I'm actually not sure why some of my patients don't have even higher EPO levels. But these are the folks we'll give EPO shots to. So let's give them more hormone. Maybe the kidney isn't providing enough of that hormone to the bone marrow to signal it to make more red blood cells. So we're going to give more. We're going to give shots of it. And we're going to give a ton of it. We're going to just flood the bone marrow with this hormone. And what it's going to do is stimulate the remaining normal bone marrow cells to make more red blood cells. It's going to try to stimulate those dysplastic cells, the MDS cells, to make more red blood cells, but they can't. They're broken, remember? So it's going to squeeze every last ounce of production from the remaining bone marrow cells. And EPO works about 35 to 40% of the time. So one of the things I'm always frustrated with MDS, if you go to the doctor and you have high blood pressure and the doctor gives you a blood pressure pill, it's going to lower your blood pressure a little bit, right? It's almost always going to work at least a little bit. The drugs that we have here don't work all the time. In general, they work about a third of the time, in a third of patients. So, and you can imagine, who's EPO going to work better in? Well, people who have low EPO levels. The higher your EPO level, when you walk into a doctor's office, the less likely giving more EPO is going to work. So a normal level of EPO when you walk in is going to be less than 25 on a lab. If you have a number that's less than 100 with MDS, we consider that low. But I've had patients who've walked into me, brand new diagnoses, who have EPO levels in the thousands. Me giving that person more EPO, it's never going to work. So one of the things that, if your doctor hasn't done this, make sure they check your EPO level before starting giving more EPO. Now there's another drug, so this works on people who have low red blood cells. There's a second group of folks who have MDS that's associated with, it's called a ring sideroblasts, or a specific genetic mutation that's called SF3B1. Ring sideroblast, if you imagine a pathologist, we do a bone marrow biopsy and we do an aspirate, we suck out some of those cells. We then hand it to a pathologist. Pathologists will look at the cells we've sucked out, and that's where they look for the blast percentage. They'll look at the biopsy of the bone that we give them, and they take a machine that slices it like a deli slicer, very, very thin slices. They then put one of those slices on its side and will add dyes to it. And some of the cells will take up some of the dyes, some won't take up the dyes. And they give different dyes to it, and that's how they determine the differences in the cells in the bone marrow. They look at it under a microscope. So one of the things they can pull out, there are some cells that have this beautiful kind of greenish ring around the outside, bluish greenish ring, and that's called a ring sideroblast. Ring sideroblasts we now know are associated with a very specific genetic abnormality called the SF3B1 mutation. All of these genetic abnormalities, they'll drive you nuts. They're all combinations of letters and numbers, and I haven't been able to make sense of most of them. But this is what this one's called. If you have this one, there is a drug that's approved that's called luspatercept. It was approved 2 years ago. And this drug is kind of like the hormone EPO. It works on the remaining normal bone marrow cells, but at a different stage of their growth to make more red blood cells. So it treats anemia. It also may work on the ring sideroblasts themselves. We're not 100% sure of that. But it's another kind of approach to it, right? So these are folks who have anemia. Now you're starting to get into folks who have very specific subtypes. There is a study that's going on right now that's seeing if this drug also works in people who don't have this abnormality. The choice of people who have this abnormality for this drug was arbitrary. I was actually at the meeting. It wasn't based in any kind of deep science. It's the fact that people who have ring sideroblasts tend to have an improvement in their anemia to cells like this more than other people. So the company that manufactures this just capitalized on this and said, okay, we're going to identify this as our target population. It doesn't have anything to do with the science, though. It was just an observation. So this other study may show that luspatercept works just as well in people who don't have the ring sideroblast, and everyone can get it. A third approach are for people who have lower risk MDS with anemia who have something called a deletion 5q abnormality. What the heck's that? Well, we all have 23 pairs of chromosomes, and they're numbered 1 through 22, and then we have the sex chromosome. So I'm XY, right? Makes me biologically male. Women are XX, makes them biologically female. If you imagine the chromosomes, all this genetic material, I kind of look at it like they kind of look like a person. They have a central part called the centromere, then they have 2 arms and 2 legs. People who have the deletion 5q, when that cell tried to copy itself and it made an error, and that error eventually led to MDS, the error in this case is that it dropped one of the legs. That's a deletion of, when you see a Q, that's the leg, P is the arm, of chromosome 5 leg. So in these patients, there were a bunch of studies that were done that showed that the drug lenalidomide works really, really well. So I'm sorry, with luspatercept, it works about 35 to 40% of the time. With lenalidomide, in people who have the deletion 5q, it works 67% of the time. That's really, really good. That's our best for lower risk MDS. Now, it's perfectly reasonable if you have lower risk MDS, you start here with EPO. That works great. You ride that wave. When it stops working, you go down to lenalidomide and use that afterwards. You don't have to start with lenalidomide because you have the deletion 5q. Those are kind of our, now lenalidomide we can also use in patients who don't have deletion 5q. So let's draw this as this, 5q with a line through it. You can also use lenalidomide that's off-label. So the FDA label is for deletion 5q. Off-label, lenalidomide works about 25% of the time. So it does work, but not nearly as well as in people who have deletion 5q. Questions about treatment of anemia? Bob? Yeah.
I have RCMDRS, whatever that is. And I know the EPO, which is part of COVID. And my ferritin level is all over the map. I've been above 1,200
That's a really sophisticated question, Bob.
I'm still considered anemic, even though my iron level is dangerously high.
So ferritin, we can get to, we'll get to iron in just a second. I'm going to take that as a separate kind of category, and I have my very strong bias about it. So I'm going to acknowledge that right off the bat. So what Bob's talking about is that as you get more and more transfusions, you get more and more iron in the body. And you can get iron overloaded. And iron overload is something that could be dangerous if it occurs over enough years and at enough of an iron level. The casual way we measure iron is through this test called ferritin. Now, ferritin can reflect iron levels or it can't. And because ferritin can also go sky high in reaction to inflammation or to other things that are going on in our lives. So it's not an accurate measure of iron overload, but people use it all the time. Okay.
And I'm not.
Yeah. And you see, and so you're a classic example of that, right? It's probably reacting to inflammation or some kind of growth in the body, like the bone marrow growing cells, and not directly reflective of iron levels in you. Okay, other questions about treatment of anemia? So, low platelet counts in people with MDS. What I'm talking about is treating the predominant low blood count. Only about 6% of people with MDS have just a low platelet count associated with their MDS. Only about 6% have just a low white count. Most people have anemia. Probably over 80% of people with MDS have anemia. Sometimes it will be in combination with something else. So as we're treating somebody who might have multiple low blood counts, we really focus on the predominating problem. What's causing this person the most trouble right now? And then we target that. So with a low platelet count, we don't have a lot of options for something that's just going to target the platelets. We have 2 drugs that are approved by the FDA that have been studied in people with MDS. One of them is called Myelodysplastic. The other one is called L-Trombopag. Now, Myelodysplastic is a shot. L-Trombopag is a pill. Both have been looked at in people with MDS. The bottom line of these, it's complicated. So these are not on label for MDS. These are both FDA approved for the treatment of another blood disorder called ITP, idiopathic thrombocytopenic purpura, where people's immune systems are attacking their platelets and getting rid of them. And it's also approved for the treatment of aplastic anemia, which they're talking about in the other room, where the bone marrow is completely gone kaput, it's failed, and you're trying to stimulate more platelet growth. So like EPO, these drugs stimulate the cells that make the platelets. So instead of EPO, we call these TPO for thrombopoietin agonist, TPO instead of EPO. The better of the studies that have been conducted, but it's reflective of both of the studies, randomized people to getting either Myelodysplastic or placebo when they had a low platelet count with MDS. On that study, the Myelodysplastic worked about 40% of the time. 40%, and the same is true of the L-Trombopag, 40%. The problem was that on the study, they enrolled people who had excess blasts in their bone marrow. And these drugs, TPO in particular, EPO to some extent, can stimulate not only the growth of red blood cells or platelets, but also the growth of blasts. Remember, blasts are the bad guys, those kindergartners. But they're mature enough that they have a receptor on them that TPO in particular can grab onto and cause it to grow. So the initial study of the Myelodysplastic, and I participated in it when I was still up in Cleveland, we actually saw people who had, 5-6% blasts. We gave them the TPO, all of a sudden they had 25% blasts. Whoa, that's scary, right? We just push them into leukemia. So we immediately stopped the drug. Fortunately, the patient's blasts went back down where they started, but that didn't happen for everyone on the study. Some of them, the blasts remained high. They were actually pushed into leukemia. So we gave feedback to the company that makes the raw Myelodysplastic to say, on the next study, don't enroll people with excess blasts. Bad news. The company ignored us because they were concerned that it would take too long to enroll enough patients to the study if they excluded those who had excess blasts. So patients were enrolled onto the study with excess blasts, and sure enough, the study was stopped early. Why? Because more people on the raw Myelodysplastic arm were transforming into acute leukemia than on the placebo arm, because the raw Myelodysplastic was stimulating those blasts to go up over 20% blasts. So for that reason, and so eltrombopag's drug development was sneakier. They initially used it in people who already had leukemia, already had excess blasts, and said, oh, we're just going to give this so that those patients who aren't taking any more therapy will have platelets that rise. So the excess blasts were hidden in people who already had excess blasts. They then started to use it in patients with MDS, and guess what? The same thing happened. It also stimulated the blasts to go into leukemia. So these drugs are approved for other indications. I will use them in some of my patients who have MDS, but never, never, never in someone who has excess blasts. And they work about 40% of the time. Now, more commonly, what will happen is that patients who have low platelet counts will be treated with the drug azacitidine or decitabine, either as an subcutaneous under the skin shot or intravenously, or there's now a pill form of the decitabine. Now, I'm not going to talk too much about these because Dr. Chandok is really going to focus on them. I will tell you that in folks who have lower risk MDS, these work about 35% of the time to improve blood counts. The one other thing that we use, we talked a little bit earlier about immunotherapy. There is one type of immunotherapy that we will use in folks who have lower risk MDS, particularly those who have multiple low blood counts, and that's called, so I'm going to kind of lump these two groups together, and that's called ATG, antithymocyte globulin. We're essentially treating MDS as an immune disorder, that the immune system somehow got tricked and attacked the bone marrow and got rid of some of these cells and caused some of these abnormal cells. And we do think that occurs in some people with MDS. So we've conducted a study here in the US. There's also a study that's been conducted in Europe, and it shows that if you give ATG to people, it works about 35% of the time. It does require a hospitalization. Have any idea where ATG comes from? It's from horse serum. And it turns out it works very, very well for people who have aplastic anemia, complete bone marrow kaput, because the immune system attacked it and got rid of it. So it kind of tricks the immune system. But it turns out that our bodies don't like to see the serum from another species. Who knew? So people can have pretty severe reactions to this, and that's why we treat it in the hospital. And I would recommend, this is the sort of thing, you don't want to go to a local hospital where someone walks in your room and says, gee, this is the first time we've made ATG, right? I've actually had people feed that back to me. They've come from other places and said that someone actually walked in the room and said, whew, I had to look in the instruction manual of how to make this. It's always bad. So you want to go to a place where they're used to giving ATG, not because there's any magic to the ATG at those centers, but because they're used to managing the side effects of the ATG. All right, questions about all of this? This is the basic treatment landscape of lower risk MDS. So the question is, where does it convert from, when it converts from lower to higher risk MDS, where is the line? How do we say that all of a sudden it's magically higher risk? And that is such a complicated question, because our definitions for lower and higher risk are based on what I previously had up here on the whiteboard, that IPSS, right? But the IPSS was only developed and validated in people at diagnosis They are not valid. They don't work in people once they've already a year or 2 years into living with their MDS. And they have only sporadically been validated in people who ever got a drop of therapy. So we actually, when I was in Cleveland, we contributed information to develop the revised IPSS. We sent, information on 400 patients who had MDS. And about half of that information was returned to us with thanks but no thanks. These patients actually got treated for their MDS. We're only focusing on people who were never treated for their MDS. So, I'm backing into answering your question, I promise. So, we have essentially staging systems that are only supposed to use up front and only in people who never get a drop of therapy. What the heck do we do when someone is now 3 years into therapy? We see their blood count shift. Maybe we see the accumulation of blasts, and when do we say, okay, you're no longer lower risk, you're now higher risk? We basically eyeball it. Right? Because there isn't a system that's validated, that's in common use to identify those folks. I will tell you, we published a system a year ago that uses this artificial intelligence machine learning programming that does work dynamically, in other words, in real time with people. You can use it at diagnosis, you can use it 3 years into the diagnosis, it's just as accurate. But it requires now that a doctor enters information into an online website about you and then wait for it to spit out a score and a value. And that is, I think, the wave of the future. So it's, for the most part, agnostic to treatment, meaning that whether or not you got treatment doesn't influence it. It should be pretty accurate either way. Okay? But it now takes somebody going onto a website and entering that. And the system that we developed, which was published in our top-tier cancer journal, Journal of Clinical Oncology, a year ago, the molecular IPSS, which was just published this year, both of those, ours I know works dynamically. I think the IPSS-M works dynamically. I haven't seen that in writing, though. But for the most part, let me make it really, really easy. Blood counts drop, blasts increase to more than 5%, genetics worsen, we're going to say it's now higher risk. Yes?
I always find my white cells at normal level, but doctor started a treatment with the refractive, and after that, my white goes.
Your whites increase.
So he stopped the treatment for that reason. So I'll find out which is the best treatment for MDS.
So what's the best treatment for MDS, particularly when the reticrits seem to have a side effect? It raised your white blood cell count. It may have done that because, remember the very first whiteboard I had here with the cells and how they develop from that stem cell, right? So when we give something like reticrit or like the TPO, they can also stimulate other cell lines to grow as an unintended consequence, right? Because they still maintain those receptors for these hormones. They're growth factors. All they do is turn a signal in a cell that says grow, make more. So sometimes the increase in the white blood cells isn't dangerous and you can keep going. Sometimes the increase in white blood cells might mean that the diagnosis is shifting, that things may be changing in the bone marrow and needs a new bone marrow biopsy. But if it went away after the reticrit was stopped, it was probably just a side effect to the reticrit. And then you start to go down this path of trying other drugs to improve the anemia. Remember, each of these, look at these numbers, each of these is only going to be working a little better than a third of the time, which means for 2 out of 3 people, they're not going to work. So you try one, if it works, great, ride the wave. If it doesn't work, move to the next one. Again, you're going to have 2 out of 3, it's not going to work, 1 out of 3, it will. If it works, great. If not, move to the next one. So you keep marching down here, right, trying different drugs until you find the one that works. Yeah? Yeah. So,
getting worse, or it's just that the medicine is not working? Maybe this person has the same amount of the blast, it's still fewer than 5%, for example, but it's just maybe the medicine is not working. How do you do this? We are there right now.
so there are just, I'm just going to repeat it for folks who are logging in on video as well, so they make sure they hear. I picked up 2 questions there, both of which were really good. The first is, let me start with the one, I'll do it kind of in order of how we think about it. If somebody has MDS over years, even decades, do you routinely repeat a bone marrow biopsy to see the stage of where the MDS is and see if it's gotten worse? The second question is, when someone's been on a drug like darbepoetin and the hemoglobin has slowly been shifting downwards over time, at what point do you say, okay, it's not working and let's move on? For the first question, we do not routinely repeat bone marrow biopsies unless we're forced to. So if I see, if I have a patient who has stable blood counts over years, MDS usually doesn't trick you. MDS usually tells you when it's getting worse in the bone marrow. And we see that because the blood counts change. The blood counts can get worse and worse and worse, or we can see one of the blood counts all of a sudden getting higher, right? And it can shift into nearby diagnoses. So instead of a pure MDS, it might be MDS overlapping with a myeloproliferative neoplasm, like a diagnosis like chronic myelomonocytic leukemia, CMML. And that's why we often treat CMML similarly to how we treat MDS. But it may be shifting. So if I see a change in blood counts, I don't do it on a one-shot deal either, because you know what, labs can screw up. I'm not going to send you for a bone marrow biopsy because my lab screwed up. So if I see a change, I will bring you back earlier. I'll check the blood counts again. If I see that change continuing, that will trigger me to do a bone marrow biopsy. For lower risk MDS. For higher risk MDS, that Dr. Chandok will get into this, it's different. Now, if I have a patient who's on a drug like darbepoetin and I see the hemoglobin is starting to drift, my first step is going to be to maximize the dose of the darbepoetin. And in my mind, the maximum dose is 500 micrograms given every 2 weeks. So first step is to increase the dose. See if maybe what we have now, there aren't enough normal cells there to respond to it. So we're going to give more of it and see if the remaining cells really, then we can squeeze a little bit more out of them. If that doesn't work, once I see someone's hemoglobin drift into the 8s, now we're getting into close to you need a transfusion area, I'll stop it. I will do another bone marrow biopsy because now the blood counts have changed. And then just to make sure it's still lower risk MDS, I don't want to treat someone with the wrong drug, and then I'll recommend another drug.
Have they changed their way we do the bone marrow testing? Because I heard it's very painful, but I heard some other people say that it wasn't painful for them. Is there a different way of doing it? Doesn't want to do it.
Well, I'm going to...
Tell people that if you have the option, you are going to die or you're going to have a bone marrow biopsy, you might want to take the choice of die.
Well, that's a positive outlook, Bob. It's not that painful for everyone. There are people who are obviously averse to it. We use the drill. There's some people who still do it manually. I've heard from my patients, I've actually seen a publication on this about people tolerate the drill better as long as you can get out of your mind that you're in a dentist's office.
Can they do it out of...
Amos actually did. Almus actually did my first bone marrow biopsy.
I'll feed back to him what a positive experience that was.
That if you do that to me again, you're not going to stop.
And he's actually, we started with him, and after all these years, we came back here. So he's his actual doctor. But this is a question, can they do a total anesthesia with the tumor?
I mean, the answer is you can knock somebody out. It won't be total anesthesia. We don't like to do that because you're introducing risks from anesthesia itself that are much higher than the risks of the bone marrow biopsy. Nobody loves it. Nobody wakes up in the morning and says, I'd love a bone marrow biopsy today. I'm not going to try to sell you the fact that it's a pleasant experience. There are different ways of doing it, and people with different skill sets of doing it.
Well, 2 weeks later, I went to the VA with the results, and they said, we can't use those. We're going to have to do our own bone marrow. 2 weeks later.
I said, Diego,
Hmm?
Diego is doing like that.
Yeah, well, I told them, your name is Carlos, they will call you Carlito, if you heard me.
So we'll be taking sign-ups to do Bob's next bone marrow biopsy after this session. All right, I think we're at 10:15, so I have to wrap it up. Thank you all for fabulous questions. And I'm sure you will love Dr. Chandok's talk on higher risk MDS also.
Thank you, Dr. Sekeres, for sharing your time and expertise with us. If you would like to watch the session again at a later time, it will be available on the conference platform in the next hour by accessing the session and clicking on replay, or by navigating the on-demand tab in the platform hub. If we were not able to answer your question today, you can send it to us at any time in 3 ways. You can send an email to help@aamds.org. You can call the AAMDSIF helpline at 800-747-2820, extension 2, or you can submit a question on our Facebook page. If you are watching online, please take a few minutes to complete the session survey. Your input is important to us and helps us plan future educational programming. Also, be sure to visit the exhibit hall and chat with the conference sponsors. The next educational sessions will start in approximately 10 minutes. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and for making us your resource of choice for information on bone marrow failure diseases. The AAMDSIF Medical Advisory Board and team are here to help you and your family as we have for the past 39 years. This concludes the session.